All right, good afternoon, everybody. Welcome to the radiology review track, pediatric imaging session. We have about an hour and a half this afternoon. We have three really excellent speakers and myself, and we're going to go through a series of cases today. The goal of this is really to provide basic information and hopefully clinically useful information through both didactics and lectures. We'll have time for questions at the end. Goal is to stay on time and keep things moving along. So hopefully this is useful to you. I'm going to go first here giving a talk about radiography in the NICU. So the theme of the session today is imaging of neonates and infants. So I'm going to be talking about basics about radiography in the NICU. Then John Choi is going to be talking about imaging of the neonatal and infant brain. Shaylee Lala will be talking about congenital lung lesions and other neonatal lung disease. And then Jennifer Crusair will be talking about neonatal and infant bowel fluoroscopy. And I'll be closing up the session talking about imaging of VUR and GU obstruction. So we're going to go ahead and get started here. And there's my first slide. Perfect. OK. And timer started. Excellent. Great. Okay, so I have no relevant disclosures. You saw my other disclosures on the introductory slide there. So by way of outline for my talk, I'm going to talk about lines and tubes, since those are of particular importance in the babies in the neonatal ICU. I'm going to talk about some important chest findings and diagnoses, focusing on things that need to be dealt with. I'm not going to cover everything here. Shaylee's going to cover some of the other stuff here, but there's just not enough time to go through it all. Talk a little bit about important abdomen findings and diagnoses as well, again, focusing on things that need to be dealt with. And I'm going to share a few tips and tricks for somewhat confusing or complex cases. So lines and tubes that we commonly deal with in neonatal babies or neonates, endotracheal tubes. Obviously, many of these kids have lung abnormalities or underdeveloped lungs, so they're frequently intubated. Umbilical catheter is somewhat unique to infants in the neonatal ICU because they have the patent vessels in the umbilicus that can be taken advantage of to get both arterial and venous access. And then once they start shifting over from umbilical catheters over to PICCs, those become important as well. So here's a radiograph of a patient with an endotracheal tube in place near the level of the carina, rapogal tube in the stomach. Keep in mind that neonatal tracheas are very short, and the tip of that endotracheal tube can move a lot with the position of the head. So when you're talking or advising them pulling tracheal tubes back, be careful how much you tell people to do that. Another general tip here, take advantage of your PACS features and systems to help better identify the position of lines and tubes. So here's a patient with a rapogal tube in place, a right upper extremity PICC. Take advantage of your sharpening function to highlight the radiopaque markers on the tubes and the inverse function to further highlight. And in this case, you can see that that right upper extremity PICC is actually extending up the right internal jugular vein. A bit difficult to see on that first image. So do take advantage of some of these features that are built into your PACS to help you characterize the position of these tubes. So basic facts and guidance about central venous catheters. Obviously, we want these directed toward the heart because they're delivering medication that needs to be dumped into large volumes of blood. Ideally, for lower extremity approach catheters, you want the tip of those catheters above, the venous catheters above the level of the renal veins, so you avoid thrombosing the renal veins. And in general, we do not want these catheters in the heart because large bore and small bore catheters can both sort of whip around in the heart or can embed in the heart and can cause lacerations or cardiac damage. So speaking about umbilical arterial and umbilical venous catheters, these have somewhat of a unique course that is important to be familiar with. The umbilical arterial catheter comes in through the umbilical artery, so they're both coming in at the level of the umbilicus. It goes down through the umbilical artery to the iliac artery and then comes upward along the course of the aorta. So it has this sort of looping course over the lower abdomen to get into that iliac artery. The umbilical venous catheter takes a more straight approach. It comes in through the umbilical vein, goes into the left portal vein, crosses the ductus venosus, and then goes into the IVC. So on the frontal radiograph, it looks like it has a very straight approach. On the lateral radiograph, as you'll see in a little bit here, it has more of a posteriorly directed course to get back to the inferior vena cava. There's a nice pictorial essay published in AJR all the way back in 2003 by Al Schlesinger and Mike DiPietro, as well as Richard Braverman, that goes through some detail about these catheters. In terms of positioning, ideally you want the umbilical venous catheter tip in the inferior vena cava below the level of T9. Lower extremity central vascular catheters, ideally you want that tip position between T9 and T11. And then upper extremity catheters, ideally the tip below the confluence of the brachiocephalix, so getting into the superior vena cava, but no more than 2 vertebral bodies below the carina. So here's an example of that. Here's an upper extremity pick. We see it on the right side coming in here, tip projecting here. So if we outline our trachea here, and there's the carina, 1, 2. This tip is right at 2 vertebral bodies below the carina, so just right at the margin of satisfactory position there in the superior vena cava. Lower extremity picks, again, I said you want that tip to be somewhere between T9 and T11. So on the first image here, the catheter tip was way up in the heart. We asked them to pull it back. Catheter tip settled down right around T9 here, so at the upper level of where we want it to be, but in more satisfactory position. Why is that? So here I've taken a MIP image of a contrast-enhanced CT, and I've superimposed on it a yellow MIP image of the ribs to sort of help us count rib levels here. And so here's T12. And so what you can see on both this image and the magged up image here, the T9 to T11 landing zone that I was talking about here, that gets you above the renal veins and below the level of the inferior vena cava junction to the heart. So that's typically where we are targeting. That's going to put you right in sort of the retrohepatic or just slight infrahepatic inferior vena cava. It is important to be very diligent about assessing these lines. Positioning is very important, so anything that looks slightly amiss, questions should be raised. So here's a right lower extremity pick that takes a course here. It looks like it's near midline or even slightly to the right. It's just not quite right, but there's a lot of distended bowel here. An additional image of the chest here with even slightly better position demonstrates that catheter to be entirely to the left of midline. So this was an arterial pick. So even though they should know this clinically, sometimes they don't. So if things look suspect, do not hesitate to raise question about the position of those catheters. Other sort of odd things you might see with central vascular catheters, there is a subset of patients, particularly patients with congenital heart abnormalities or even variant anatomy. You can have a left-sided superior vena cava or bilateral superior vena cavas. Left